We know that's sometimes difficult.
Because of that, I think it has taken over.
So welcome back to the next episode of Endoscopy Essentials, and a warm welcome to Mouen Khashab from Baltimore. We're going into another exciting EUS-guided intervention that's called EDGE. What's EDGE?
EDGE stands for EUS-directed transgastric ERCP.
Okay, so it's connecting two stomachs together against the will of the surgeons sometimes, but it's after gastroenterostomy for obesity.
Yeah, it's a Roux-en-Y gastric bypass for obesity, and it is temporary reversal of the bypass procedure, of the bypass surgical procedure.
So is it now standard for bypass patients?
For centers with expertise, interventional EUS, I think this has become the standard of care. Some endoscopists or some centers were hesitant initially because of the risk of permanent reversal. But now that we have data of that this is not common and there are ways to close it, and some difficult cases where we need a lot of instruments to close it, but we can close it. So the risk of permanent reversal is negligible basically. And now that we have data, more and more people are using this technique, because the alternative, as you know, is enteroscopy assisted ERCP.
Which is often far away.
Far, and the success is about 60%. I think with a short double balloon, especially in Asia, you see a little higher results, better results. But when we compared both techniques, and the success was 100% for EDGE, 60% for balloon-assisted enteroscopy. So because of that and the need of repeated procedures in many of these patients, the really good results with EDGE. I mean, the first paper we published on it, the 178 patients, the success was 172. So that's including the initial experience at the participating centers. Because of that, I think it has taken over at the majority of university hospitals.
And of course, there's the percutaneous approach, which is mostly, not always, done by the radiologists, and is a different story. So there's nothing wrong in trying one enteroscopy if you are conservative, but your preference would be EDGE at the moment.
Yeah, I mean, you know, some endoscopists, their deep expertise is in deep enteroscopy, and they're very particular about that and very passionate about that. And if they have, of course, it needs patience and will and persistence and expertise. So if that's available, and especially when interventional EUS expertise is not available, then that's the way to go.
Yeah. Okay. So let's go into the procedure. Again, general anesthesia, preferable?
Yes. You know,
I'm a big fan, so you don't have to convince me.
But when I say that, you know, now I pay attention. There's a lot of places in the world that don't have anesthesia support. It's difficult. So I will say general anesthesia is more important in patients with undergoing EUS-guided gastroenterostomy, because that's usually the stomach is full. Here, the stomach is empty.
And small,
and you will get access to the remnant stomach, and usually it's filled with fluid, so you have to make sure you're going to aspirate the fluid right away. It's a relatively long procedure, because you're doing this is like 3 in 1, 3 procedures in one. So it's a prolonged procedure, and the patient, preferably they're on their back or prone position. So we always use general anesthesia.
I'm greatly in favor, but
yes.
We know that's sometimes difficult. So please walk us through. You have this nice life case
yes.
together with Pierre Dupré, I see.
Yes, so I was lucky to have Pierre with me, and we played tag team, with EUS and ERCP in this patient, and let's walk through it. So this is just an EUS scope in the gastric pouch, and we're looking under X-ray and EUS. Now the EUS view is on, and we're looking for the remnant stomach, and I'm gonna search, and here it is.
There was a lot of rotation, huh?
There's exploration and rotation, and this is typically how it looks. We call it the sand dollar sign, and initially I had to look what a sand dollar is, but now it's exactly this. So this is a typical sand dollar there. And you see the rugae of the stomach, and usually it's collapsed. In some patients, you get lucky and you can get some fluid like this. And in some patients, you have a lot of fluid, but typically it's collapsed.
Any differential diagnosis? Colon?
No, the colon will not look like that. And but you're not going with lambs now, right? You're gonna fill it, and you're gonna basically double check that you're in the stomach. So now we are going to target it with a 19 gauge needle, and the first thing we're gonna do is just use a 10 cc syringe of contrast through the 19 gauge needle and inject contrast to ensure that we are intraluminal. So here I'm just letting it play slowly. Of course, we turn Doppler on to ensure there is no major vessel, and go with a 19 gauge needle. This is a collapsed lumen, and the wall is not under tension. So you see here how you're just gonna indent. So it's typically you go through and through, and then you pull back. It's there's nothing in the back there. Not sure why they went on the EGD view, but we're still seeing the EUS view there, and we're gonna go
indenting, and here you are.
And now when the stomach is really collapsed, you really want to inject some contrast and make sure the contrast is flowing in the stomach and not staying in one spot. If it's staying in one spot, it means you are intramural.
Yes.
So now, then usually the first injection is in the antrum. And you see here, you're very close to the pylorus, and the contrast is passing to the small bowel. It doesn't matter where you puncture the stomach. That's not where you're gonna put the lambs. This is just an access point to fill the stomach. Once we're happy with it, which means we are in the right spot, we are intraluminal and not intramural, we attach the needle to a pump. And the fluid is made of saline and contrast. Saline is important because you inject a lot of fluid. We don't want to cause any electrolyte abnormalities. So we give glucagon. You typically in this procedure, just 1 milligram is okay. In gastroenterostomy, we do repeated injections. And here, probably I thought we are a little bit more distal than I want. So we turned.
It's still going into the distal stomach and duodenum. So you pulled the needle back? No.
Here I pulled back because because
you did a second puncture.
Yes, because the contrast you see was emptying into the small bowel right away. So I thought let's pull back, and that happens. And you see here the how collapsed the lumen is.
Yeah.
So this is when you want to do your 10 cc syringe. And
see whether it opens up with fluid.
Yeah, if it opens up and that the contrast is not staying in one place.
So you might have to manipulate the needle a little bit if you're attached to the contralateral wall.
Correct. And let's see here.
Now it's opening up.
It's opening up.
You have to be patient.
Yeah, I mean, this is, and you're seeing here how it is starting to fill. So now we are happy with it. And the position is better because it's more proximal. Position is good. And again, that doesn't matter where the needle is. Multiple punctures in this patient. But now, I'm going to pause it here and talk about something important. So we filled the stomach by puncturing distally in the antrum. So the first injection was very close to the pylorus. We repositioned, but it was still in the antrum, but we were able to fill the proximal stomach. This lamb's placement should be in the proximal stomach. If you place the lambs in the antrum, the ERCP becomes very difficult because it's very hard to get through the pylorus. You can't get your angle. And also we know lambs and antrum, they're not friendly with each other. So we try to avoid the antrum.
But here you did a third puncture, right?
Correct.
For filling.
Correct.
So you filled the proximal stomach, went up, and then hit it again.
What happened is, you look at the small bowel. So the distal puncture, the pylorus basically is very patent in this case, and the fluid is not getting retained. But what happened here is that the stomach became a little bit more dilated proximally, then repuncture was okay. And that's fine. It's a dynamic process. The multiple punctures is not a big deal. What you want to establish is full distension of the stomach.
Yes.
So now once you have a gastrography, you pull your scope and angle it towards the proximal stomach as we are doing here. Because your target should be the proximal stomach. And how do you know where the proximal stomach is? By looking at x-ray.
Yeah.
And it's really important to go to the proximal stomach. Otherwise, ERCP is going to be very, very difficult.
So this is the position to be.
This is the position to be. And
Here we are already.
And this is the lambs, 20 millimeter, of course.
Same as with the gastroenterostomy.
Yes, and here's
Not-
one thing
not
I want
too
to show you.
quickly.
Always slowly.
Yeah.
And these days, we do auto cut, we do effect 6. It used to be lower effect. Now we do effect 6 because we really want a smooth puncture. And here you're going through double muscularis propria. You have the muscularis propria of the pouch and the muscularis propria of the remnant stomach. So there is a lot of puncture, a lot to puncture here. So it's slow. And here I want you to look at the distal part. You see how we're indenting the wall of the stomach? So because you want to push the catheter all the way in so that the stent is deployed in the lumen. We know that the stent doesn't get deployed at the tip of the catheter. It gets deployed more proximal. So to push all the catheter in, you frequently have to indent the stomach. The nice thing is you can indent it without pushing it away. So, but the way you do it is you do it slowly. So here, and I replay the video, you're seeing indented there. So I was able to push the catheter all the way in. And now look where the lambs, look how it pulls back. So this is a 20 millimeter. And now we're pulling back. So this is the, let's see if we're seeing the inside catheter there. And we pulled, you see the catheter now touch the edge of the lambs.
That's for everybody to have watched our previous episode.
Yes. And now we turned into the endoscopic, so we deployed the stent inside the channel, and then we looked at the endoscopic vision, and we deployed the second flange. So the two ways to do this procedure is one is single session, and one is a stage technique. Stage technique means you just put the lambs, come back in a week, and do the ERCP. The stent will be fully open, and the track semi-formed, and then you can do the ERCP, elective ERCP.
If you have enough time, if it's not an emergency.
If it's not an emergency. For us, most people in the US are comfortable doing a single session, but to be able to do single session safely, there are multiple criteria. One is 20 millimeter lambs placement, not 15. Two, dilate the lambs to 18 millimeter, and then anchoring of the lambs. So I know this increases the cost and the time, but if you don't anchor, then you will see migrations and every now and then. And that is a perforation that may not be easy to repair. So
it's mostly distal migration then.
It is.
You push it in.
Push it in.
Yeah.
It is this flange here you're seeing, it goes inside the peritoneum. So we just saw a case yesterday during Endo Club where they anchored the stent with a stent fix device, and that worked very well. And recently there was a small publication of single stage edge using anchoring the stent with a stent fix, and that worked well. With the overstitch device, since we already opened the device, we like to suture on both sides of the lambs. So place 2 sutures. The way we do it is we get a bite on the wall, then stent, then wall, and we like to get good bites. And now after this, we are ready to proceed with the ERCP.
So the stent should be fixed twice at opposite sides? Or
Yeah. Well, so
so that means 2 stent fix?
So no, here's the issue. We wanna also be careful with the cost. With the overstitch device, the main cost is the device itself, not the suture. Since you have the device opening up a second suture is a minimal increase in cost. With a stent fixed device, if you go 2 instead of 1, you're doubling the cost. So 1 is possibly good enough. We really can't comment on that. There's just one paper on this. But what I've seen is that it works. But again, 20 millimeter stent, dilate, anchor. And then the fourth important thing is when you're doing the ERCP, the scope has to pass kind of fluidly, nicely, without much resistance and without much angulation. If you're having a lot of resistance, please stop and bring the patient back a week later. And in some patients, the pouch is really dilated, it's big. Over time, it dilates, patients just bad eating habits. And then you're trying to push the ERCP scope through the lambs, and then you retroflex in the stomach. So that can be some difficulty. It is worth trying a few times, but it can be difficult. These are the cases also you bring in a week or so.
So maneuvering the scope through the stent is an issue. Any tricks? Is it sometimes necessary to place a guide wire? No.
No, so the way when I teach my fellows, I say, think about it as a pylorus. So you want to target the upper part of the stent, and you look at the upper edge, and then the scope should go through nicely. And also you can look at X-ray.
Yeah.
And as soon as you pass through, you just do a right turn. And then this is how you go towards the pylorus. Occasionally, you can go more proximal to the fundus, and you just have to look at X-ray, make sure you're turning right.
Okay, good. Any other tricks here at this stage? So you said dilatation up to 18. 18.
One.
Fix it. Fix it.
Fix it.
If you want to do a one-step procedure?
Yeah, just single stage. Again, 20 millimeter, dilate to 18, fix it, and then make sure the passage of the ERCP scope is smooth. And if you can accomplish all of that, we have enough data right now to prove that this technique is reliable and very safe. I personally have not had any migration when I followed these 4 rules. These are cardinal rules for edge, for single stage edge procedure. The other difficulty that can happen sometimes is passing through the pylorus. And usually the reason for that is the stent that you placed is a little bit more distal. But sometimes it will be more distal. You sometimes don't have a lot of choices. It's the most dilated part of the stomach is not the proximal body, maybe distal body. And then you get in and you don't have enough room to angulate or optimize the approach to the pylorus. And this can be difficult. And a lot of times we have to dilate the pylorus and then anchor, with the balloon, and then pull, change patient's position. So in these cases, one thing that can help is put the patient on the left side. As we do with ERCP
like with
sometimes.
a typical pylorus, yeah.
Yes. So turn the patients on the left side, and that can help. I've had, I think, one case where it was just very hard to get through the pylorus. It was just a lot of pushing and pulling, and I elected for the patient to come back. And I actually got another ERCP scope from another manufacturer where the scope is more flexible. And it helped me just approach the pylorus in a different angle, and it worked nicely.
So sometimes it's little details you don't appreciate, but then,
Okay. Yeah, going through the pylorus, people don't talk about it a lot, but it can be challenging sometimes, yes.
That's right. But once you're there, it's ERCP like ERCP. So do you have to be more careful with moving the scope? Or
I'm going to show you here. So this is the advantage of Edge, is that you just do a normal ERCP. So the position is normal. And you see here, Pierre, just standard body position, standard scope position, standard equipment, and you're just doing a normal ERCP. Usually, with ERCP, once you get to the papilla, there isn't much movement. So you're more stationary and some body movement.
Unless you need a long position and that kind of stuff. But that's no concern about that.
No concern, because you're once you get here, there's no issue. Yeah.
Okay, great. So that's intubating the papilla and
again,
the usual tricks.
we're not gonna show you much of this case here, but you can do advanced cases, cholangioscopy, whatever you need. This is the beauty of it. If you're doing enteroscopy assisted ERCP, you can't use these advanced equipment, and then in patients with strictures, post-transplant leaks, where you need multiple procedures, then you're not gonna you need to redo the procedure, a long procedure. Here we have direct access.
Great.
Perfect.
Thank you.
Thank you, Thomas.